I'm doing my AMA presentation today, and the question or the case that I looked at was how should long-term psychotherapy address ethical questions during the palliative care of a patient with a serious and persistent mental illness. And here's my table of context. So a few things we're going to be going through today is the summary of my chosen case, legal and ethical considerations, possible parameters and solutions to solve these legal and ethical considerations, important stakeholders in the issue, and finally, a few follow-up questions for in-class discussion. So here's a summary of the case. Um, Basically, the article is discussing using long-term psychotherapy as a form of palliative care for patients with serious and persistent mental illness, such as treatment-resistant PTSD that was mentioned throughout the article. And when recovery or remission is not possible, palliative psychiatry focuses on improving quality of life and relieving suffering rather than curing illness. Long-term psychotherapy provides a stable, trusting relationship that helps patients manage the stress, despair, and suicidal thoughts while allowing for shared decision-making about care goals. And a couple ethical challenges include balancing patient autonomy with legal obligations and avoiding the misconception that palliative care means giving up. And despite practical barriers like limited access to psychiatrists and insurance coverage, integrating psychotherapy, medication management, and social support as a part of palliative psychiatric care can significantly improve life quality for patients with chronic mental illness. So, what are these legal considerations? Well, first, the duty to warn and protect. Psychiatrists have a legal obligation to intervene if a patient poses a clear and imminent risk of harm to self or others. And this includes mandatory reporting of suicidal ideations or threats of violence, which can conflict with patient confidentiality and trust. Second, informed consent and capacity. Evaluating and documenting the patient's capacity to make informed decisions about their care is critical, and this includes discussions about the goals of palliative care versus curative treatment and advanced care planning. Confidentiality limits. Legal requirements are going to compel a psychiatrist to disclose information to protect the patient or public safety, as mentioned prior. Um, Additionally, advanced directives and care planning. Psychiatrists should assist patients in creating psychiatric advanced directives to document treatment preferences, including preferences during episodes of incapacity or decompensation. Fifth, balancing autonomy and paternalism. Legal framework guides what is permissible to override patient autonomy. For example, to continue medications in psychosis or when the patients lack decision-making capacity. Six, documentation and legal protection. Through documentation of critical clinical decisions, capacity assessments, and ethical discussions will protect both the patient's rights and psychiatric's legal responsibility. And then finally, regulations. Psychiatrists must comply with local and state laws regarding healthcare treatment reporting and involuntary hospitalization or treatment procedures. And these legal considerations are required for psychiatrists to navigate complex ethical dilemmas carefully while prioritizing patient safety, autonomy, and quality of life in palliative psychiatric care. Ethical considerations. There's a lot. First, respect for autonomy, which means honoring the patient's right to make informed decisions about their care, including understanding and choosing between curative and palliative approaches, while supporting their capacity and involvement in advanced care planning. Beneficence. Acting in the patient's best interest to relieve suffering and improve quality of life, even when cure or remission is unlikely. But this means that we still have to provide a compassionate, consistent, and supportive care. And that's what the point of palliative care in psychiatric situations is for. Non-maleficence, avoiding harm by carefully balancing interventions such as deciding when to use a medication or restrict autonomy temporarily during psychosis, and managing risks related to suicidal ideation. Truthfulness and transparency, being honest about prognosis and treatment limitations while maintaining hope by reframing goals, such as aiming for symptom relief or stability rather than full recovery. Confidentiality, Maintaining trust through protecting patient privacy, but also clearly communicating the limits of confidentiality related to legal obligations. IG explaining that if a psychiatrist believes that they are at risk of suicide or at harming others, then that is something they have to report. Um, Justice and access. Addressing disparities in access to long term psychotherapy and palliative psychiatric care is essential for vulnerable patients so that vulnerable patients are not neglected, especially because so many of these vulnerable patients are the ones in need for these resources and structural support. Therapeutic alliance. Building and maintaining a trusting, stable relationship that supports open communication about difficult topics, including existential distress and end of life considerations, all while managing ethical tension, especially because these are very difficult topics to talk about. And then finally, avoiding therapeutic nihilism. And what does that mean? It basically means that psychiatrists and those involved in palliative psychiatric care are being very careful about not labeling care as palliative does not lead to giving up on patients or reducing efforts to relieve suffering and explore new treatment options when available. And these ethical principles will guide psychiatrists to provide humane, patient centered palliative care. Possible parameters to solutions. Um, Here are a few things to consider when looking to develop best solutions to address a couple of ethical and legal challenges in long term palliative psychotherapy for serious and persistent mental illnesses. Obviously, we have patient centeredness, which is where we prioritize the patient's values, preferences, and goals of care. And we also want to ensure meaningful involvement of the patient in decision making and respecting their autonomy, all while providing education and support. That means prioritizing those patient's values and preferences, even if it's not what we would necessarily do in that situation. And trust. Trust is a big one. We want to foster a strong, stable, and transparent relationship that encourages open communications, especially because there will be handling of difficult topics like suicidal thoughts or end of life care. And another big one is legal compliancy and clarity. So we really want to clearly communicate the limits of confidentiality and legal obligations to patients upfront, which can be awkward to begin with. But we also want to maintain through documentation of capacity assessments, consent, and discussions to protect both patient and provider. A few other things that could be essential to look at would be ethical flexibility and responsiveness. Just as not every situation will be the same, we really want to balance respect for autonomy with beneficence and non-maleficence and adapting responses to changes in patient condition. And we really want to avoid the previous topic of therapeutic nihilism, where palliative care is viewed as giving up. And especially because there are so many groups of different people involved in this, we really want to maintain that level of multidisciplinary collaboration and involve social workers, medical providers, family, and community resources to address all of the prior issues mentioned. Um, but who's involved in all of this? As you said, a lot of people are involved in this. So there's actually a lot more than you think. And important stakeholders in long-term psychotherapy include patients, obviously, as they are central to the care. They're the ones receiving the care, so their values, preferences, and needs all are going to drive the treatment goals and ethical decision making. Next, we have psychiatrists and mental health providers, and they're the ones who are delivering psychotherapy and medication management and are navigating ethical and legal issues all while building a therapeutic alliance with their patients. And obviously, we have family members and caregivers, which are going to be there to provide emotional support, help with daily care, and often participate in advanced care planning and decision making, or even just ask questions. We will also have a lot of other team members, such as nurses, social workers, and primary care physicians, who will all address holistic needs beyond psychiatry. Because if you're not healthy all the way around, you can't focus on that. And then we have insurance providers and payers, which influence coverage decisions. and affect access to long-term psychotherapy and palliative care services. And finally, we have legal authorities, which are going to set laws and guidelines governing patient rights, confidentiality, duty to warn, and involuntary treatment. And these are only a few of the people involved. There's a lot more involved. You could name the healthcare institution or the clinics that are working or advocacy organizations and policymakers. There's just a lot of parts involved in this. So a couple follow-up questions, which I thought might be interesting for a class discussion. The first one is, how can clinicians strike a balance between respecting a patient's autonomy and fulfilling their legal obligations when a patient expresses suicidal thoughts during palliative psychiatric care? And in this situation, I think it's very complicated because at the same time, if you breach or uphold confidentiality in such cases, it definitely swings both ways. Personally, I don't know what I would do in that situation. I think there's definitely a balance there, but ultimately clinicians have to respect the legal obligations because that is their license that they can lose. I think ultimately it is up to the law at hand. But I think when that patient expresses those thoughts, it is the clinician's job to support them through it. Second, in what ways might labeling a psychiatric treatment plan as palliative influence how patients, families, and providers view the prognosis, and how can we prevent this label from being misunderstood as giving up? Personally, I've experienced this because my dad was in hospice care for cancer, which is obviously a different thing, but I think it's just making it upfront of like, it's not giving up. It's just making people feel as comfortable as possible as they can. And no one likes to see their family suffer, or no one wants to suffer. But it's definitely essential to focus on labeling, sort of labeling it rather than it being like end of life care or giving up as something that's just meant to make people as comfortable as they can within their circumstances. Um, and then three, given the limited ability of long-term psychotherapy and financial barriers in mental health care, what strategies could systems or policymakers implement to make psychiatric care more accessible and sustainable? Um, Personally, I think a lot more financial support needs to be given into mental health care, and especially into helping people in vulnerable communities and accessing these resources. And I think a lot of people sort of become discouraged when they do go for help and it doesn't feel like it's helping. But it might be worth changing the idea of not like curing, but just dealing with it and learning to live as comfortably as you can with it. Learning it, yeah. And these questions I thought would encourage students to think critically about the legal, ethical, and structural challenges of implementing compassionate long-term care for individuals with chronic psychiatric conditions. Ah, that was a lot. But so, in caring for individuals with serious and persistent mental illness, long-term psychotherapy as palliative care offers a compassionate, ethical, and realistic approach, especially when traditional treatments fail to bring remission. And by focusing on quality of life, trust, and shared decision making, we can help patients find meaning, stability, and relief from suffering. And as clinicians, advocates, and fellow human beings, our responsibility is not always to cure, but always to care. So, in the words of Hippocrates, to cure sometimes, to relieve often, to comfort always. So, even when cure is out of reach, comfort and dignity are never